Hello, I'm Adam Dolby, Chair of the Queen's Healthcare Leadership Forum. Welcome to our first video podcast, which we hope you will find interesting and informative. First of all, thank you for visiting our website and for showing an interest in the content of our website. We hope to keep adding to it throughout the academic year. So, today's talk is on leadership. What exactly is it? We have an entire society dedicated to leadership, so we thought that a good first video podcast would be to define what leadership actually is, and particularly what it is in the context of healthcare. This video podcast is based on our first ever event that we held as a society in November 2012. So I'd like to thank the speakers who featured at that event: Michael Guerin of Medicare, Michael McBride, the Northern Ireland Chief Medical Officer, Nevin Ringland of Praxis Care, and Eddie Rooney from the Public Health Agency, all of whom gave fascinating insights into what they thought leadership was in each of their relevant sectors of healthcare. So as an overview to this video podcast, we will start off by discussing concepts of leadership. So what is leadership in general? So how would you define it? Then we'll move on to healthcare leadership and defining what specifically healthcare leadership is, and some examples of what healthcare leadership is. And then we'll look at what qualities make the ideal leader. Are leaders born? Are they created? What characteristics do they have? Can you learn to be a good leader, or is it something that you naturally have or don't have? And then we'll look on a more personal level at how you personally can be a good leader. So, we'll start off by looking at some concepts of leadership. Leadership is one of those terms that is frequently bandied about by politicians, judges who are returning reports, specifically on failures in healthcare systems, and by business leaders. It's a fairly woolly term, and people often see it as just a throwaway word, and nobody really explains what it means. Look at this quote from Tomorrow's Doctors from the GMC, for example. Doctors of the future are expected to offer leadership and work with others to change systems when it is necessary for the benefits of patients. So their definition suggests that it's to do with working with others, because that's mentioned, changing systems, so it suggests that there's a role of change within leadership, and that it's all done for the benefit of patients, which is why most doctors go to medical school anyway, so it's kind of obvious that there must be some leadership traits required in every graduate, which is suggested by that phrase from the General Medical Council. So as well as the General Medical Council, the Royal College of Nurses have also come out in favour of leadership, that general vague term we keep returning to and will do for the rest of this podcast. So excellent clinical leadership is recognised as fundamental to the provision of high quality care and creating a culture of innovation and support in the workplace. So that's the Royal College of Nurses have gone for a fairly similar angle to the General Medical Council. The mention of culture and support highlight the importance of people, and high quality care is mentioned, and you assume that means high quality care from both the perspective of the patient and the perspective of the profession. We'll be doing another talk in future on what high quality care is, because it's fascinating the differences between what medical people see as high quality, so the nurses, the doctors, and what members of the public see as high quality care. But that's for another day. So leadership is more commonly applied to an individual, saying so-and-so is a leader. So on this slide we've put lots of pictures of different people who could be classed as leaders in different fields. There's the chair of the Royal College of General Practitioners in the top left. There's a local leader, Cathy Jack, is in the bottom left-hand corner. And there are political leaders as well: Margaret Thatcher, David Cameron, Barack Obama, Tony Blair. There's another, of course, famous healthcare leader on there from the nursing profession, Florence Nightingale. Leaders from business, Steve Jobs and Bill Gates. Obviously couldn't mention either of those without bringing the other one in for the sake of balance. And another female political leader, Angela Merkel. So these people are called leaders, but what makes them leaders? Arguably, these people have been leaders, with the exception of Florence Nightingale, because of a position. But then Florence Nightingale later on went to a higher position within her profession anyway. So was she a leader before she was a highfalutin member of the nursing profession? I would argue that she was, and we'll come to that later on in this podcast. So let's look at the theory of leadership. You can throw the word leadership and leaders around like crazy, but what does it actually mean? Well, a few merely business-orientated academics have looked at leadership, and they've decided that it consists of kind of a three-part stage in being a leader. So there's future, which is providing a vision. So say you wanted to achieve something, you state what you want to see. So you say that you wanted to see a reduction in post-operative infections on your ward, in the healthcare example. Or a businessman wants to see a certain growth in his product line, or a certain growth in his base profits. You then engage, which is the second part of the leadership cycle, as it were. So you get others on side, you talk to people, you try and sell them the vision that you've come up with in the previous stage. It's not the same as communication, which is vitally important. Anyone can communicate anything. Some are obviously better at it than others. But communicating suggests that you're telling somebody something. So you're saying, you will do this, you won't do this. Instead, with leadership, engagement is more about saying, look at this, what do you think? Would you like to join me in trying to make this happen? And you're getting other people's ideas as well as focusing on your own ideas. So it's not a selfish thing like communication suggests it would be, where you're saying what you can and can't do. You're saying that this is what I want to do, but will you help me find a way of doing it? And the final stage of the leadership cycle, delivery. So you've got to motivate people to follow you through with your idea, because sometimes change isn't liked by people, and generally organizations and people are resistant to change. So you've got to motivate people to go along with the change to achieve your vision, and you've got to sell it to them. You've got to inspire them to act. So it's no use telling somebody that they should be doing this because you tell them to. You should be saying, if we do this, together we can achieve this as a team, and our patients will have much better outcomes, and we will be respected more as an organisation because we have achieved this together. So as well as the leadership cycle that I've just been talking about, there are other ways of viewing what leadership is. So you can say that it's managing change, setting agendas, and that's not agendas for us on a small scale like a meeting agenda. That's the vision that we've just been talking about. And there's a quote from Peter Lees, who's the head of the Faculty of Medical Leadership and Management, www.fmlm.ac.uk, if you wanted to have a little look at that. And he said it's about getting results through and with people. And that's not even a medical-orientated statement of what leadership is. Leadership in business, leadership in politics, is all about getting results through and with people. So people are central to leadership. And it's not the person who's actually doing the leading that's central to leadership. It's the people around him who he's trying to lead who are central to it. And the best leaders let other people take credit for things that have been achieved, rather than taking all of the credit themselves. And again, this is highlighted here. To lead people, walk behind them. You need to engage people by letting them lead you to a certain extent. Leaders turn visions into reality. And if you want to know why your people are not performing, look in the mirror. So rather than blaming everybody around you for something that's gone wrong, you need to start looking at yourself and seeing why they are not being properly engaged with your leadership style to achieve your vision. So in summary, that's pretty much what leadership is. It's about leading people to achieve a specific vision by engaging them, to achieve a change that produces specific outcomes or achieves a more general vision. I think this, particularly in a medical setting, is important. there's always the thing of management versus clinicians. And people wonder why they should be engaging with leadership, because isn't it the same thing as management, and management are evil? Well, A, management aren't evil, they're just doing a different job from clinicians. And B, management and leadership are slightly different things. So these are some quotes that we had from speakers at one of our events, which I thought were quite good. So leadership is doing the right thing. So again, achieving that big vision, seeing what that vision is, engaging people in order to deliver that vision. Whereas management is doing things right. Management is a little bit more about process. Leadership is more free and loose. You don't really know what the outcome will be at the end of it. You may not achieve your vision in the end, but you've tried. And there are lots of uncertainties in leadership. Management has a lot more certainty in it. And there are processes that have been established to make good management. Whereas leadership is freer and more uncertain. So, as a healthcare leadership society, we should probably explore healthcare leadership. So, healthcare leadership, also known as clinical leadership. I've already mentioned that a lot of professional organisations endorse this generic term leadership. So we had the Royal College of Nurses and the General Medical Council. So the difference between leadership in general and leadership in healthcare is that leadership in healthcare's more specific aim, the vision, is improvements in quality of care or improvements in outcomes as a result of care provided. So it's, as you'd expect, it's leadership focused on healthcare. There are formal leaders and informal leaders, which is an interesting concept, particularly in healthcare. The them and us that I mentioned earlier of management and leadership and clinicians. So the formal leaders are those who are in official leadership roles, such as medical directors or nursing directors. But the informal leaders are the people I'm particularly interested in personally. These are the people who don't have formal titles, formal responsibilities specifically of leadership. The informal leaders are the junior doctors, for example, or the student nurses who come up with an idea for improving patient care and then implement that change by working with others without being in that specific formal position. The people who take up the initiative and actually do something to improve patient care of their own volition. And we hope that the overall outcome of the Queen's Healthcare Leadership Forum being in existence is that we create a lot of these informal leaders who bring about change that improves patient care and improves outcomes. And we hope that we inspire people who maybe would have before seen leadership as something for somebody else to do at the top of an organisation, that it's not actually about that. It's about people at all levels of the organisation coming up with a vision and then implementing that vision through working with others. So again, why healthcare leadership? Well, overall it's to improve healthcare systems, which produce better outcomes for the population as a whole. But what areas does healthcare leadership improve? What does it focus on improving? So there are some examples here. Quality, which is the degree to which health interventions for populations and individuals increase the likelihood of desired health outcomes, improve health status, are consistent with current professional knowledge, and meet public expectations. Again, I mentioned earlier a talk on quality that we're going to do at some point, and that one sentence just demonstrates how complex the area of quality is. But in general, it's about improving the quality from both the perspective of the clinicians, the well-informed parties of those who are providing healthcare, who understand the healthcare provision from a population point of view, and the patients themselves, who may not understand the technical outcomes that happen, but understand that it's bad if they get an infection in hospital, or bad if they see that the area in which they're being treated is untidy, even to the extent where they think it's bad healthcare if the member of staff is rude to them, or calls them by their first name without being invited to do so. There are also improvements in performance. which is a separate aspect from quality on this slide. You could argue that they're fairly similar areas, but performance in this context is focused on safety, improving the safety of our care. Obviously, healthcare is no use if it reduces the health of somebody after it's been received. Effectiveness, the efficiency, the appropriateness, the timeliness and responsiveness are all aspects that have been classed on this slide as performance related, although they are linked in some way to quality of a care, because you could argue that if a care isn't efficient, it's not high quality because it's using up resources in one area which could be better used in another area. And overall, there's the cost and quality paradigm, which is an improvement in quality is actually more cost effective and could arguably cost less. There are obvious examples of this that you can think of. One example that springs to mind is where you're actually doing something that has no evidence for it. So where you encourage the use of prophylactic antibiotics in a patient with congenital heart disease in order to reduce the risk of infective endocarditis. Actually doing that is low quality care because it costs more in antibiotics that are actually unnecessary. The evidence base and the advice from NICE suggests that just normal oral hygiene is good enough for preventing infective endocarditis, rather than prophylactic antibiotics before a procedure. So not only is that care cost effective because you're not paying for the antibiotics, it's also high quality because it's evidence based and you're not risking side effects of antibiotics on patients who don't actually need them. There is actually an evidence base for leadership and a positive link between effective clinical leadership and improved patient care. It's fairly easy to see why this link exists. If you have a group of doctors, of nurses, who are constantly envisioning an improved quality of care, improving outcomes, then they're going to be more motivated to try and implement changes to achieve that vision. And if staff are motivated to actually engage with others and deliver that outcome, then of course the outcomes will be delivered, and thus effective clinical leadership has led to improved outcomes. Of course, it also works the other way. So if clinical leadership and engagement is ineffective or absent, then the outcomes will be poorer for that organisation or that institution or that ward. And there are numerous examples where lack of leadership has been quoted as something that has caused an environment where patients have come to harm or reduced quality of care has been delivered. The most recent example, of course, is the Mid Staffordshire scandal. And Robert Francis quoted in his report that he felt that it was a lack of clinical leadership and a poor engagement of leaders with clinicians that had arguably contributed towards the things that had gone wrong in Stafford. So, let's look at some examples of clinical leadership, or healthcare leadership. I've picked two examples just to show leadership in action and to try and help better define it. Because I hope by the end of this podcast, people will have a better understanding of what leadership is, and when somebody uses a woolly term such as leadership, it sort of makes a bit more sense. So the two examples I've used are one from a doctor and another from a nurse. I've picked these two professions just as two example professions. Of course, they equally apply to dentists, pharmacists, and other healthcare professionals. But if I'd picked one from each profession, I'd be here all day and this podcast would be horrendously long. And of course, these examples are given as qualified practitioners, but they could equally apply to students being engaged with processes on wards and being a leader as a student, which is possible. Indeed, leadership as a student has been encouraged recently. In July 2013, Sir Bruce Keogh wrote a report into 14 NHS trusts in England and specifically stated that nursing students should be encouraged to engage in healthcare improvement, leadership by extension. And he appealed directly to the nursing directors at hospitals to engage nursing students specifically, as well as junior doctors as well. So the first example, you are an F1 doctor on a medical ward, and you notice that a lot of GPs are calling you with questions after a patient discharge, which suggests that they're not getting the information that they need in the discharge letters or discharge summaries. So this is really a case in a problem with communication between primary and secondary care. So what do you do? Well, obviously an option is to do nothing. Another option is to do something, which hopefully, as a budding leader, you would actually want to do something about this. So obviously you need to collect some information to decide what best course of action is. So you need to probably conduct an audit into what the GPs are asking when they ring up. If all the GPs are ringing up asking the same thing, then it's obvious that they just need a single piece of information. But if they're ringing up asking different things, then it's more complicated than it looks. So how can you act? Well, obviously that depends on the initial problem. So if it's a single piece of information that GPs keep requesting, then you could easily, arguably, change the template of the discharge letters so that that piece of information is then provided by default by whoever fills in the template. If it's more complicated than that and it's a range of things that are missing, maybe there's something more complicated, a more complicated solution that's required. Or maybe a different way of thinking completely is required. So for argument's sake, let's say that it's a single piece of information that's missing. So who do you need to involve? Well, it's the GPs who are receiving this information. So maybe if you suggested to them that you were making this change, they may come up with other ideas that they have that would improve the discharge template even more. And you tell them, of course, that you're making the change that you originally noticed was a problem. You need to involve the junior doctors on the ward and all the other doctors on the ward who are filling in the discharge letters, as again, they might have other ideas, or there may even be a reason that this piece of information isn't being provided to the general practitioners. And you also need to involve the nursing staff, because it may affect something that they do, or they may have suggestions of their own as to how the discharge letter can be improved. There's no point in leaving out people who aren't obviously involved in typing out the letters and reading the letters, because you may miss out on a useful idea from somebody else. So it's always important to engage as many people as possible. And obviously the final one is what needs to be changed overall. And can it be organisation-wide, or is it just this ward that it applies to? And so you need to communicate the change once you've made it, and noticed, of course, that it's successful, to other wards on the hospital, to other doctors, to other hospitals, or even to other trusts. So here's the leadership cycle for that case. Your vision is to improve communication between primary and secondary care. The engagement, you need to speak to other doctors, the GPs, nursing staff, management, ward clerks. And your delivery is to work with stakeholders, i.e. all of the above, the people you've engaged, to deliver your solution and to improve patient care. So you change the template on the computer system, you see how it goes, and you note whether there is an improvement in communication between primary and secondary care, arguably probably measured through whether GPs keep ringing you asking you for that piece of information, which, if people are filling in the template properly, shouldn't be happening. So the second example. You are a staff nurse on duty on a new ward. You notice that this ward has more patients getting bed sores than on the previous ward you worked on. So this is a problem of nursing care, quality of nursing care between two wards. Or is it? It could be the type of patients that are on this ward compared to your other ward. So there may not even be a problem at all, but you've noticed that there's something awry compared to where you worked previously. So again, answer the questions. What do you do? Again, doing nothing is an option, but we'd hope you'd like to do something. What information do you need? How do you collect it? How can you act? Can you put in a process to ensure that patients aren't forgotten? and that they're turned frequently if they're immobile? Who do you involve? Again, this is similar to the previous example. You need to involve everybody, even those who are not directly involved, because it may affect things that other professionals are doing that you haven't thought of. And what needs to be changed? Again, that's your overriding question. And does it need to be changed just on that ward or organisation trust-wide? So some of these cases are quite good if you think about them from the vision, engage, deliver as a cycle. So your vision is to reduce the incidence of bed sores, engage with other members of staff, doctors, sisters, the ward manager, staff on the other wards, have a look at the literature, and then delivering by working with the stakeholders to achieve your vision. So now a little look at what makes the ideal leader. There is a huge argument in academic circles as to whether you can teach leadership. There's an excellent insight from Picasso about artists who says that all children are born artists, but the struggle is staying as an artist as you become an adult. What he means by this is that as you grow older, society makes you conform and you lose the artistic flair, because to be an artist you need to be unique. And I think the same applies of entrepreneurs and of leaders. So as you grow older, society makes you conform and you lose a little bit of the vision, which is what leaders need, as we've discussed in the previous section. So I'll leave that up to the listener as to whether you think that leadership can be taught or whether it's something that you're born with. But I personally think that everybody has the potential to be a leader. They just need to challenge the status quo properly. So here are just some words that have been used to describe leaders. So is a good leader adaptable to changing circumstances? Are they self-confident? Do they have an ambition to strive to climb to the top of an organisation? Are they proactive in finding things that need changing and doing that? They have a vision? Are they reliable? Are they decisive? Are they motivational people? Do they inspire confidence in others? Do they inspire people to act in certain ways to achieve things? And does a leader have integrity? So these are just some of the words that have been used to describe leaders. Some of them maybe don't apply to all leaders. I mean, are all leaders ambitious? Is a nurse on a ward or a nursing student on a ward who sees something that they want to change being ambitious for themselves, or are they being ambitious for their patients and for the system in which they work? So Michael McBride had this slide that I've stolen from him. What are the dimensions of the best leaders from the literature? So they have genuine concern for others. They're an effective communicator, networker and achiever. And by effective, they're inspirational. They empower others to lead, so they can take a backseat themselves when the circumstance suits. They're transparent and they have integrity. They're accessible, approachable, and flexible. They're decisive, determined, and prepared to take risks. They clarify individual and team objectives, so they're not obscure people who translate their vision poorly. They may have a general vision in their head, but they're good at translating it into something that other people can understand and engage with. They're team-orientated, and they involve everybody in crises, in problems, and in shared values. So they're not just the king of their organisation. They're a uniting figure, so they have this vision that everybody shares, and they work with others to achieve it. They challenge the status quo, which I think is one of the most important aspects of leadership. They support a culture within an organisation of development. And culture is another one of those woolly terms, but it's basically the environment that you create either as an individual or as a system that encourages what people should and shouldn't do. So if you have a system where laziness is rewarded, people are going to be lazy. But if you have a system where innovation is encouraged and people are rewarded for trying new things, even if they fail, then you're creating a culture where that kind of behavior is acceptable. And you're going to achieve more by doing that than by punishing people who try and innovate and fail. So the ideal leader is also an analytical and creative thinker. And they manage change sensitively and skillfully. And I think we've established by now that on the leadership cycle, the biggest aspect of that is change. It's all about introducing change or having a vision for change and engaging people to deliver that vision. So, is the ideal leader the INFJ personality type? Introvert, intuition, feeling, and judgment. So the introverted person is quiet and reserved, and they prefer interacting with a few close friends rather than a huge circle of acquaintances. Intuition, preferred to sensing, they prefer to be abstract rather than concrete in their ideas, and they see the big picture rather than the small minutiae that are associated with their ideas. The feeling, so they don't really think things through specifically, they use gut instinct more than logic to solve problems. And judgment is preferred to perception, so they plan their activities and make decisions early. And they like a sense of control through predictable circumstances. So this, of course, is the rarest of all the personality types. But does it make an ideal leader? At first, we've just been talking about engagement of people. It doesn't necessarily make sense that somebody who's introverted as opposed to extroverted would make the better leader. But I'll leave the listener to decide on that. Michael Gurin provided this table in his talk at our introductory event on different types of leaders. I think these have all come from, this research has come from the business world. There's a mention of sales and things in there. And I'll leave those who are interested to have a read of that table and have a look through the different types of leaders: the opportunist, the diplomat, the expert, the achiever, the individualist, the strategist, and the alchemist. And the most important drive behind leaders is their underlying values. Their underlying values drive the vision and create the vision. It's because they've got certain values that they come up with a vision that they then want to deliver. So values are guiding principles for individuals and for organizations. And as much as they seem like woolly management talk, values are very important, because if everyone's working around a given set of values, they're more likely to achieve outcomes because the culture is created where that kind of behavior is acceptable. So I've just mentioned that values are an important aspect of leadership. And values influence behaviours. So what I've done, I've stolen these from Hull and East Yorkshire Hospital's NHS Trust, and these are their behaviours which are based on their underlying values that they wish to aspire to. And these are all over the hospital. They're on the screensavers, they're on posters, and they're basically saying to anyone who goes in that hospital or hospitals within the trust that this is how we behave because we believe in this. So these values ensure a culture of equality, improvement, dignity, and respect. So I will is used. There are the I will values. So these are promises that the hospital is making to its patients by displaying these values everywhere, that all of the staff are dedicated towards these values and acting in this way. So, I will look to continually improve the way that my service is delivered. I will look for ways we can rather than reasons we can't. I will look to you and value the opinions of others and treat everyone as I wish to be treated myself. I will always look for things to inspire me and to remember to say well done and thank you. I will remember to make a difference to patient care, quality, and safety every day. And so these behaviours are leadership behaviours in healthcare, and I couldn't think of a better example of an organisation encouraging people to be leaders, and it's one of the best examples I've actually seen. So finally, how can you lead? Well, you need to think about what your vision is. Who are you serving, first of all? Are you serving patients, members of the public, the system at large, your managers? What are your underlying values to your vision? Why do you think that your vision is important? And why is it important to you? And how will it be important to others? Do others share your values so that they can also share in your vision and help contribute towards that vision? What needs to change within the organisation? What measurable targets do you have? And how will you measure whether you've been successful or not? You need to think about who to engage. Think about all members of the team from all levels within the organisation, both above and below you. Remember that you do not want to miss out on an opportunity by not engaging as many people as possible. Even people who are not specifically directly involved with the aspect that you're trying to change may have some good ideas about how to bring about change that you haven't seen. And finally, think about the best way of delivery. Look at the literature, involve others, measure success, and communicate that success to others. And the most important thing is you can lead as a student. So look around the wards when you're on placement and think, how can this be done better? Or how can this be improved? If the vision of the health service is providing high quality care to the population which is free at the point of use, start off with that as your vision and tweak it personally. And that way you can think about being a leader whilst on placement as a student. And you can even go the next stage and speak to people who work in the hospital or other healthcare environment on which you're on placement about trying to be a leader yourself, as well as just thinking about being a leader. And speaking about the importance of leadership, not just as healthcare professionals, but as student healthcare professionals, here's a quote just to end with. Leadership is not about a position or a place. It's an attitude and a sense of responsibility for making a difference. And I'll leave you with that quote just to think about. So in summary, we've looked at leadership from the perspective of being a cycle of vision, engage, deliver. We looked at some different qualities and styles of leadership and of leaders. We've looked at healthcare leadership and tried to define it and give some examples. And I think the most important aspect of this whole podcast has been that you don't have to be at the top to be a leader. And that's the main message of the Queen's Healthcare Leadership Forum. So thank you for viewing this video podcast today. You can keep in touch with the Queen's Healthcare Leadership Forum by following us on Twitter at QUB Health Leader. You can find us on Facebook. You can email us at healthcareleaders@qub.ac.uk, or you can visit our website at www.qhlf.co.uk. If you would like to be further involved with the Society, please do send us an email. We're looking to have a very, very representative committee this year. We already have lots of nursing students, lots of medical students, but we're very keen on getting pharmacy students and dentistry students engaged. So if you're from either of those professions, please do get in touch and you'll be very welcome to join on the committee. Thank you.